Okay, good afternoon, everyone. Can you see my slides?
Yes, doc.
Yes, doc.
Yes, doc.
I hope, let me know, please interrupt me if I'm coming to you garbled or choppy, okay? So, for today's lecture, I'll be talking to you about uh, bone tumors, no? Mostly radiologic signs, cues, and clues that will tell you whether you're looking at a lesion that will probably be aggressive or non-aggressive, no? So, I'm choosing to use the term aggressive because there are benign tumors that can be aggressive. No, a good example of that is osteomyelitis. No, um, so and as you know, the whole topic of musculoskeletal radiology is rather quite long. No, in the reference that we're using, it's about factors. So I'll be as short as I can, but I'll give you the important things. No, it's very difficult to to explain to lecture to you everything that is on the book. So the second part I will probably include the rest that I'm not be able to discuss today. So when it comes to diagnosis of bone tumors, no, or bone lesions, X-rays, radiographs still play a big role. In fact, it's the initial study usually done by most clinicians. So before going to the more advanced imaging modalities like CT or MRI or even radionuclide scanning, if you look at this flow chart, no, uh, mainly this including radiographs and the use of computed tomography, you look at how basic clinical information can be used also to narrow your differential diagnosis. No, so you look at the chart. It basically tells you that what you're looking at are what you call the method that you use is called pattern identification. No? It's a method that will more or less give you a clue of the behavior of a lesion. No? If it looks very aggressive or very less aggressive looking, which may or is usually your um, tumorous or okay. So okay, if you look at this chart, uh, usually the patient may be symptomatic or asymptomatic, and usually you start with an X-ray, and you need at least two views, again orthogonal views, no, and very important. The very, very important clinical information is the age of the patient because it will help you narrow down your differentials. No, so you're presented with a set of pattern, radiologic pattern, and then you consider the patient's age because there are lesions that are common among the younger age population, like less than 40 years old, or the more than 40-year-old age bracket. No, the important point there is to segregate, to differentiate the aggressive looking tumors, so aggressive behaving tumors, and of course, to be able to confirm whether they are indeed malignant, you will have to do a biopsy. The tissue diagnosis is almost always a prerequisite um, for a diagnosis of malignant lesions. No? So again, if you look at the modalities involved here, they basically make use of the same principles. So X-ray is makes use of radiation going through matter, and then of course it shows you the same pattern of densities that you would appreciate also in computed tomography. Main advantage of computed tomography is that it's able to display a wider area, no, and also it can present the data in 3 or 4 dimensions, no, and you may do a lot of things that you can do with anything that is digitalized. Okay, so it takes around 30 to some literature will say 30% or maybe up to 50% of bone loss to be able to register as an area of lytic destruction in radiographs. No? So it takes some time for that to happen, of course. But for earlier detection, you will have to turn to a modality that will show the finer details much earlier, like for example, MRI. MRI is able to display the conditions of the medulla much earlier than an X-ray could. No? And of course, radionuclide imaging can also be useful, but it gives you a very poor anatomic outline, anatomic detail. So it's more useful for determining the extent of a metastatic lesion. No? Okay. So again, going back to this flow chart, there are clues that will tell you, again, using by radiologic or radiographic assessment, that will point to an aggressive or non-aggressive lesion. Okay, so for the non-aggressive lesions, and we shall go to that later. These are some of them. They look they look aggressive, but they're actually not. No? And these are the so-called don't touch lesions. No? These are actually benign lesions that usually present as areas of bone loss. No, and we will see if we can discuss on that in much detail. No? And then, of course, you have the aggressive lesions, which you may need to do to refer the patient to a treatment center or a tumor board. And then, of course, usually what follows is a biopsy. No? Then, of course, if it turns out malignant, then you would have to find out the extent of the involvement. No? Whether, of course, sometimes you may need to, you may be seeing only metastatic lesions, but you may need to determine where the primary is. No, okay. So the do not touch lesions. No, these are usually uh, some of them are the non-ossifying fibroma or a fibrous cortical defect, usually measuring less than 3 centimeters in diameter, simple bone cysts, and small enchondromas and bone islands. These are actually benign lesions, and of course, you need to avoid doing biopsy because sometimes the biopsy will also um, mistakenly point to a possible malignancy, and you may uh, erroneously do radical surgery, and then later on for the a repeat biopsy or a review of the biopsy, it turns out that it's a benign lesion. No? That's what you have to avoid. Okay, so some of the things in detail on the radiographic assessment. No, uh, okay. So you look at pattern of bone destruction, zone of transition, periosteal reaction, whether there is or there is no periosteal reaction, cortical destruction, and soft tissue or joint involvement beyond bone. So we'll go over in detail these radiographic features, no, and they of course have to point to either a non-aggressive or an aggressive type of lesion. Okay, remember, a benign lesion may look aggressive, but actually it's a benign lesion, and a very good example of that is osteomyelitis. No? So clues by appearance of the lesion. So again, we are talking about radiographic appearance. So these are CT and X-ray appearances. You can basically divide pattern of bone destruction into three main groups, no? According to how much of destruction there is that is displayed. No, one is geographic, second is moth-eaten, and the third is permeative pattern. Okay, so the most reliable actually discriminator when it comes to differentiating one pattern from the other is the most reliable is the determine is the appearance of the zone of transition, no? Whether the zone of transition from the normal tissue or normal bone to the abnormal or malignant bone is wide or narrow. Okay, if it is narrow, then you're leaning towards a benign type of lesion. If the zone of transition is rather wide, no, meaning it tends to be difficult to demarcate which tissues or bone structures are normal versus bone structures that are abnormal. No? If that tends to be difficult to determine, then you're leaning towards a wide zone of transition and you're looking at a probable aggressive or malignant lesion. Okay. Another important determinant, of course, a clinical determinant is the age of the patient. No? Age actually is the most important clinical clue. Again, of course, you know that there are certain malignancies or disease entities that are common in a particular age group. Like, for example, when you're dealing with metastatic lesions, you rarely see metastatic lesions in young children. No, you tend to see them mostly in the older age group. Okay, there are other clues that we'll be discussing along the way. No, for example, the whether the lesion is confined to the bone, whether there is soft tissue extension, or whether it's the presence of matrix calcifications, meaning the lesions inside the center of the lesion, whether it shows calcifications or none at all. So first pattern is geographic bone destruction. Okay, when you say geographic, there's a clear boundary. Okay, the word geographic implies that you're able to tell one place, differentiate one place geograph because of the geographic boundary. So the destructive lesions tend to be sharply defined, to have a sharply defined border, and it implies less aggressive or more slowly growing, most likely a benign process. And of course, the transition zone is narrow. So if you look at this lesion, this is non-ossifying fibroma. This border demarcating the lesion from the rest of the normal bone. Okay, so this uh, so how do you know if it's well demarcated? Maybe a good analogy is if you can draw a thin line like the tip of a pencil, okay, demarcating benign versus malignant lesions areas, then that is a well demarcated border. Okay, so some other examples. Okay, and then of course the second more aggressive looking pattern or appearance is moth-eaten appearance. No? So I'm probably sure you've seen clothes that have been eaten by moths or silverfish, no? Clothes or linen that you've placed in the closet for a long time, you've not opened it, and you check it out again, and it's already eaten up, no? So the area of destruction tend to be ragged or irregular. That implies a more rapid growth, no? And it's pointing to a probable malignant lesion. Okay, so here you are looking at okay, lytic lesions involving the scapula, the acromion process, including the glenoid labrum, okay, and the humeral head and the whole, practically the whole shaft of the visualized humerus. No? And there is even a pathologic fracture here, okay. So that is multiple myeloma. So a moth-eaten cloth will look something like this, no? Although there are still clear defined borders, but there are multiple irregular outlined lesions, no? So some other examples of moth-eaten lesions, moth-eaten pattern lesions, myeloma. Myeloma, in fact, is the most common primary lesion of the bone, no? Okay? Primary malignancy of the bone. Metastatic lesions. Okay, so when you say metastasis, these are the primary is somewhere else, and the spread is among other areas is in the bony structure. No? So you can have bone metastasis, lung metastasis, organ metastasis, etc., etc. Now there is lymphoma and Ewing sarcoma. Then the most destructive pattern is the so-called permeative. So when something permeates, for example, an odor permeates the room, so it spreads across the entire room, no? And of course, you have ill-defined lesions with, again, similarly appearing to moth-eaten multiple wormholes. They spread to the marrow space, and there is, of course, wide transition, and this implies a like, very aggressive malignancy. Another name for permeative pattern actually are round cell lesions. No? So round cell lesions are, for example, leukemia. Uh, these show a permeative pattern of bone destruction. So if you look at, this was an example, this is leukemia, and you can see involvement of the medullary region, even the cortical region, no? And yeah, and the involvement is very extensive, no? So if you ask me, how do you differentiate moth-eaten from permeative, no? There's actually a very thin line, no? But if the one criterion probably you can look at is you look at the endosteum, no? The inner lining of the inner cortex. If there is involvement of the endosteum aside from the medullary region and the cortex, then you probably are dealing with a what you call a permeative pattern of bone destruction. Okay, so I think I'll just turn off my camera so I have better data. No, one problem with where we live is really the signal is not really very good. So some examples of permeative lesions: lymphoma, Ewing sarcoma, myeloma. Okay, um, osteomyelitis, and neuroblastoma. Okay, so be mindful of the fact that there is also what is called as a pseudo permeative process, false permeative process. No, so okay, sorry. This type of lesions actually, that's why the term is pseudo, because it's a false permeative. It actually, the lesion actually involves cortical holes, no, cortical lesions, and do not involve the medulla. Okay, so since the cortex surrounds the medulla, then if you have lesions involving the cortical holes, they may appear to be also the holes superimposing on the medullary region, especially if you're using just maybe X-rays. No, so again, that is one example of false permeative or pseudo permeative process. So most common pathologies that manifest in this manner, okay, or so, and of course mimic permeative lesions are aggressive osteoporosis, especially from disuse, no, hemangioma, and radiation therapy. Okay, you must remember also about bones. So the bones, actually, the book mentions that the bone is one reliable indicator of the a patient's metabolic status, no? Because as you know, bone is the largest reserve of calcium. If your body needs to mobilize calcium, then it may need to remove that calcium from the bone, and you have the balance of the action of the osteoclast and the osteoblast. Now, osteoclast is destruction, osteoblast is bone building, and when you have the osteoclast working, it's you mainly see lytic lesions. There's the osteoblast working, and you see more of the blastic or sclerotic lesions, so meaning opaque or very very opaque changes in the bone involved. Okay, so again, like I said, pseudopermeative involves only cortical lesions, but the medullary region may be normal. And since they are surrounding, no, the medullary region, they can appear as if the medullary region is involved. Whereas permeative can involve at least the endosteum, okay, and you may show the same. It may show the same pattern as a pseudopermeative. No? Okay, so just be mindful of that. Okay. So again, if you compare again these three patterns of destruction, going from the benign or least aggressive looking, going to the right, the more aggressive or most likely malignant lesions, you have geographic, moth-eaten, and permeative. No? So um, if you look at the difference between moth-eaten, no, you can see that the cortex, at least in most of the areas of the cortex are still intact. Here you have industrial involvement, no, or the inner lining of the cortex. Okay, so one other feature that you also look at when it comes to looking at the pattern identification method is to look at the pattern of periostal reactions. No? So that will involve bone changes in the periostal region. So usually in a benign lesion, there may be no reaction at all, periostal reaction, or they can, if there are reactions, usually it's a solid type, meaning the overlying cortex is still intact. No? There might be layered periostal reaction, but still there is intact cortex. The more aggressive pattern of arousal reaction, they can be in layers, or again, a perpendicular to the long axis, no? Like sunburst, no? A ray of a sun. These are calcifications, incomplete calcifications radiating from the bone bone lesion, and in a perpendicular orientation to the long axis of the bone, and of course Cadman's triangle. All of these periostal reactions are rather incomplete or involve an, an a cortex that is no longer intact. No, okay. So again, to differentiate, no, this is again is obviously a geographic pattern. This is a non-ossifying fibroma. Okay, so the benign perosal reaction implies a low-grade chronic irritation, and it allows time for the formation of normal or near normal cortex. So that's why you may have layered but intact cortex overlying the lesion. Okay, so they can be wavy, they can be uniformly dense, but again, the common denominator is you have an intact cortex. No? Okay. Benign perosal reaction can also be seen in callus formation, no? When you have bone building after a fracture. No? or even some slow-growing tumors. Okay. In aggressive periosteal reaction, there is rapid irritative process that does not give time for the periosteum to form new bone or lay down new bone. So what you see is an interrupted, multi-layered periosteal type of reaction with obvious cortical destruction. Okay, so you may see that with even benign conditions like infection, osteomyelitis, no? Or even eosinophilic granuloma, neurysmal bone cyst, osteodystroma, hemophilia, and trauma. So they can be these benign conditions can appear also, mind you, with aggressive periosteal reaction. Okay, so where is the periosteal reaction here? This is solid periosteal reaction. If you look at this tibia here, no, the tibia appears more sclerotic, and you look at the cortex, it appears more opaque. And you look very closely, it's like there is a lifting of the cortex in this region here. Can you see where I'm pointing at, everyone? Can you see my cursor?
Yes, doc.
Okay.
Yes, doc.
So this is a bit fine detail, but you look at the cortex, there's some lifting, but the cortex is still intact, no? And you look at the density of the cortex in the mid shaft and the proximal third of the tibia. This is chronic osteomyelitis, no? Okay. And the lateral view also shows you the same sclerosis, and well, the layering can be seen best in an AP view. So probably this is on the sides, no? That's why you can't see it in the lateral view. Okay, that's chronic osteomyelitis. On the other hand, if you're dealing with an aggressive or malignant lesion, one example is onion skinning. So if you imagine, of course, I'm sure you're all familiar with how an onion looks like, no? Multi-layered, okay? And this is what you see here, no? Look at this area here. So aside from the obvious lytic destruction in the medullary region, what type of long bone is this? Can anyone guess? Can anyone tell me what long bone this is? There is a large head, there is a neck, and there's a shaft. What is this?
Femur, doc.
Of course,
Femur.
yes. Yeah, femur. So you can see that the lesions most likely affect the intertrochanteric region, the metaphysis, and the proximal third of the shaft. And if you look very closely, there is cortical destruction and some layering, no, and actually layering, and of course some soft tissue swelling as well, no. Okay, and this is probably a better view. It's a magnified view of that, no. So there is layering, and you can see obviously that the cortex is no longer intact, no? There is cortical destruction. That is very classic appearance of the onion skinning. Okay, so you may appreciate onion skinning in one projection. Again, that depends on where the onion skinning is happening. Like for example, if you see it here on the like in this example, if you see it no, okay, if you see it on in this view only, on the AP view, then probably the onion skinning is happening on the lateral aspect, and you would not may not see that on a lateral view of the same specimen of this femur, no? Okay, so another type is sunburst, no? And okay, if you can imagine the sun, the rays of the sun are going outward and are oriented perpendicular to the long axis of the bone. This is the sunburst appearance, with typically what you see with osteosarcoma. And a lot of osteosarcomas occur, by the way, in the metaphysis, no? In the metaphyseal region, the area of growth, no? Okay, usually occurring with patients who have not yet fused their epiphysis, meaning they're still growing. No? You see a lot of these cases in the relatively younger age group, no? I mean, osteosarcoma. Then the next pattern is Codman's triangle. No? I don't know if you can see the triangle here, but yeah, this is the Codman's triangle, and you can see some more calcifications in this area here. But there is obvious also lytic destruction in the medullary region. No? So this looks like I don't know if you're familiar with a buttress. No, when you build a wall and the wall is very high, part of the reinforcement is like a triangular reinforcement at the base of the wall. No, it looks something like this. No, so that's yeah, that's Codman's triangle. Okay, so sometimes you may see more than one type of lesion happening in a single specimen. For example, you do have in this particular example, you have Codman's triangle and you have sunburst appearance, and you also have multiple layers in onion skinning in this area here, no? And you have also um, a soft tissue mass also, no? Okay, so you may have in the real world, you may have more than one type of aggressive pattern being seen in a single X-ray specimen, no? Okay, so these are some other examples. This is a benign condition. This is osteoid osteoma. Okay, you can see that the cortex is intact, no? But there is an obvious bulge in the cortex of the middle third of the tibia. Okay, and one very distinct clinical presentation with osteoid osteoma is there is pain relieved by aspirin, no? And you see this cases mostly in young patients from osteoid osteoma. You know. And the second image here is a aneurysmal bone cyst. Okay, so there is some expansion, there is expansile change, but still you may have not you may or may not have intact cortex, no? But there is obvious what is obvious here is there is sort of a ballooning or expansile change in the area of the lesion, no? Okay, and that's why again a lot of pathologic fractures occur in benign lesions too because the bone may be weakened, no, by the even if it's a benign type of lesion, but the bone still is weakened by this the growth, no. So when you say pathologic fracture, is the bone is already abnormal because there is already a pre-existing lesion, and you may not have the trauma that's causing the pathologic fracture may not be the same amount of trauma, even less than what you would normally get when the bone is normal in the usual fracture incidents, no. Um, yeah. The third example is Codman's triangle. No? I don't know if you can see it very well here. And this is the sun ray or sunburst speculation. So when you say speculation, it's the word spicule is like small spikes, no? Calcifications that are oriented at a particular manner. So this in this example, this is oriented transverse to the long axis of the femur. Okay. So continuous lesion may be solid or expanded, but again, look at the cortex. It may be also laminated. No? Not exactly onions. When you say onion skinning, it's going to imply a malignant lesion. So this is laminated. You use the term laminated instead of onion skinning. So for all these three, the cortex is always intact. No? And there's the buttress, okay, the Codman's triangle. This is sunburst appearance and yeah, also Codman's triangle here, no? And there's lifting too. Okay, so from benign to malignant, no? Okay, so all three here are malignant types of periosteal reactions. No? So how about other areas of the tumor, like the center, the tumor matrix? No, there are also some clues that you can derive from whether or not the pattern of opacity is also leaning towards a malignant or a benign lesion. No? For example, osteoblastic lesions tend to have fluffy, colored, cotton-like or cloud-like densities, no, meaning, and this is what you see with osteosarcoma. Okay, sometimes there may be a cartilaginous tumors, no, and one very distinct appearance of this cartilaginous tumor matrix is the appearance of comma-shaped punctate or annular or even popcorn-like calcifications. No? So these are rounded or comma-shaped. No? So these can be seen in enchondroma, chondrosarcoma, chondromyxoid fibroma. Okay, but this is chondrosarcoma is a malignant lesion, but with cartilaginous tumor matrix. Okay, meaning the center of the lesion shows cartilaginous deposits. So this is the type of reaction that you see is there's increased density of the medullary region, okay, and the outline of the cortex tend to be blurred, no? And this is what you see with osteoblastic type of tumor matrix, meaning as there's new bone formation, and again, it's going to maybe another term is sclerotic, no? Okay, the affected bone appears more opaque. Okay, And versus cartilaginous, this is cartilaginous. You look at the tumor matrix, the center of the tumor, you have punctate, no? Very small dots. And sometimes some of these are comma shaped. So this is our cartilaginous tumor matrix. But you may also see that with chondrosarcoma. Okay, chondro is cartilaginous, and it's a sarcomatous type of cartilaginous tumor. Okay, some other tumors are expansile, meaning there's ballooning effect, no? So multiple myeloma, metastatic lesions, aneurysmal bone cyst, fibrous dysplasia, brown tumor, which you see with hyperparathyroidism, and chondroma. Okay, usually see these lesions with the chondroma in the phalanges, no, in the fingers, and also with lymphoma. Okay, so can you tell me where the expansile lesion is here in this radiograph? Can you see any expansile change or expansile or ballooning? Can you see it? Anyone? Look at the radiograph. Okay, since we're talking about bone, then of course you'd have to look at the bones, no? So look at the ribs. Is there any abnormal rib structure there? Okay, anyone? Hello? You still there? Hello?
Yes, doc.
Yeah, can anyone tell me, okay, the clue here, the abnormality is involving the ribs, no? So which can you tell me where or what area or what rib is involved? Okay, anyone?
The costochondral junction, doc.
Yeah, yeah. Well, not really the costochondral, but these are posterior ribs, no? So again, you have to differentiate anterior from posterior ribs, no? The posterior ribs are more cephalad, and if you follow, for example, if you look at this rib, if you follow it, the posterior rib is higher, then it turns it an angle, then the anterior part is lower. So the lesion actually here is in the posterior rib, no? It is this particular area. So if you do rib counting, probably 1, 2, 3, 4, 5, 6, probably the seventh posterior rib, no? Okay, can you see the yeah, it's multiple myeloma in this case. And of course, this is more obvious, renal cell carcinoma. Okay, so this is a metastatic lesion. The primary is in the kidney. Okay, and how about this one? Can you tell me this is a benign lesion but with expansile change, no? So where is the expansile lesion here? Can anyone tell me what particular area of the bony area is involved here? So your clue here, you see a very large soft tissue mass. Look at the soft tissue mass. Is there any abnormality in the surrounding, in the adjacent bony structures? Yes or no?
Yes, doc. In the vertebrae.
Where?
Yes, doc.
Where is the abnormality? Where is the lytic change? So let
Vertebrae, doc.
where?
Vertebrae, lumbar vertebrae.
Okay, which level lumbar
The
vertebrae?
lumbar. The lumbar. L4.
Yes, 1, 2, 3, L4. Yes, and you see here, this is the rib destruction. This is the destroyed area, no? So, what particular part of the lumbar spine is should be found in this area? Look at this normal counterpart here.
Pedicles, doc.
Yes, very good. Pedicle. So the pedicle connects the lamina to the body, lumbar vertebral body. Very good. Okay. So the this is an aneurysmal bone cyst. Okay, and this one is fibrous dysplasia. No? This there is already a pathologic fracture. No? Okay, this one is a hyperparathyroidism, brown tumor. No? You have the expansile change in the intramedullary region of the. What bone do you think is this? Can anyone take a guess? An educated guess? What bone is this? There's another
Maybe
long bone.
tibia, doc.
Yes, the middle third of the tibial shaft, to be exact, no? Okay. So how about this one? This is an enchondroma, and this is found in the where is the enchondroma found? That is the enchondroma here. Where is it located? Can you tell me where it is
First
located?
metacarpal.
In the which
First
metacarpal?
metacarpal. Fifth
The
vertebra.
fifth, very good. Okay, so this is one, two, three, four, five. No? So there is expansile, but if you look at the cortex, it's still intact. No? So you're leaning more towards a benign type of lesion. Okay. So how about this CT scan? No? It shows you, okay, the red arrow is pointing to rib destruction or posterior rib destruction. Okay. There's also lytic change and some expansion as well. Okay. So this is most likely a metastatic lesion. The primary is a lymphoma. Okay. So some other tumors, so some other conditions, there are conditions that are also more or less in a particular area of the body. No. So if you imagine, for example, the long bone along the long axis, the central axis, starting from the center and going to the periphery, no, there are lesions that are found mostly in the central area and going towards this from the center going outward. Okay, you have eccentric and cortical and parosteal. So uh, eccentric is just off center, cortical is in the cortex, and sitting on top of the cortex is parosteal. No, okay. So parosteal sarcoma, osteosarcoma, and cortical osteosarcoma are two different entities. No, and of course, they are differentiated by their origin. No? For example, parosteosarcoma tends these cases tend to have low grade malignancy, while periosteal osteosarcoma are more of a intermediate grade. So this therefore has poorer prognosis. Usually, this is rare, parosteosarcoma, and of course, with better prognosis than classical osteosarcoma or even periosteal. Classical osteosarcoma is usually periosteal. No? The most common pattern shows its lobulated mass on the posterior aspect of the distal femur. So this type of lesion actually sits um, above the periosteum, no? While this one is periosteal. No? Okay. So again, periosteal osteosarcoma, most common site is tibial shaft. No? So maybe to differentiate again, central at the medullary region, okay, intracortical maybe in the cortex, and endosteal may be sitting in the endosteum, no, on the inner lining of the cortex. Periosteal, of course, is in the periosteum. Parosteal sits on top of the periosteum, while extraosseous usually are in the surrounding soft tissues. No? So, okay, this is in the transverse plane. No? Again, starting from the center, the medullary region, as you go outward, no, then there are specific common areas of these different types of benign and malignant lesions. No? For example, enchondroma usually is central, no? Along with fibrous dysplasia. Okay, while in cortical lesions are non-ossifying fibroma, aneurysmal bone cyst, chondromyxoid fibroma, even osteoma, osteoid osteoma. No? And then a little further outward, on top of the cortex of the periosteum, there are also lesions, no? Like parosteosarcoma and osteochondroma. Okay, so in the long axis too, okay, like at the ends of the long bone are the epiphysis, then you transition to the flared portion, the metaphysis, and the more or less the cylindrical portion is the diaphysis or the mid shaft, no, which you can divide further into proximal, middle, and distal third, no. So again, in terms of the long axis, these are common locations of these different types of both benign and malignant lesions, no. So at the ends, usually giant cell tumor, chondroblastoma. At the metaphysis or the transition zone, the flared portion, osteomyelitis, osteosarcoma, osteochondrosarcoma. Okay. In terms of why, if you ask why is it osteomyelitis common in the metaphysis, if you must remember, no, osteomyelitis usually is blood-borne, and a lot of the blood supply, blood vessels are actually supplying the metaphysis compared to the other areas. So that's why you tend to see a lot of the osteomyelitis involving initially the metaphyseal region. Okay, so these are again the different areas of the bone: proximal, middle, and distal. No? And then you have the articular surfaces. That's already part of the epiphysis, and again, this is the metaphysis and the diaphysis or the shaft. Okay, there are some tumors with distinct characteristic location. For example, simple bone cyst, proximal humerus, chondroblastoma usually seen in the epiphysis, giant cell tumor also in the epiphysis. No? Okay. So this is in the proximal humerus, no? The simple bone cyst. Okay. Can you see the chondroblastoma here? Can you see the lytic lesion here? Can anyone tell me where the lytic lesion is? Or and what bone is
The
involved?
epiphysis of the tibia, doc.
The what? The
Epiphysis of the tibia.
okay, the epiphysis, or maybe to be exact, near just underneath the tibial spine, no? So this area here. So this will be the plateau, lateral plateau, because the fibula is over here in the lateral aspect, and this is the medial plateau. And this well demarcated chondroblastoma is over here in the epiphysis, no? Just underneath the tibial spines. Okay, so giant cell tumor again, the metaphysis and epiphysis of the what bone? What bone do you think is this?
Tibia.
Tibia, doc.
Yes, the proximal tibia, and also also the proximal fibula also doesn't look normal, no? Okay, so damantinoma usually is seen in the tibia, chordoma. Okay, the word chordoma, you have these are neurogenic in origin, so they may involve usually the sacrum and the clivus. Where is the clivus, by the way? Can anyone tell me where the clivus is? Where is it found? Anyone? Okay, at the base of the okay, the what?
Occiput.
Well,
Occiput.
yeah, it's actually part, not really the occiput, but show you. If I don't know if I have it here, no. Anyway, it's just part of it is yeah. I think you're in the occipital region at the base of the skull, no. Okay, osteoblastoma is usually seen in the posterior part of the spine. And this is chordoma. You can see very sclerotic changes, blastic changes involving even the vertebral body, you know, L5 and part of the ilium, no? Okay, that is a chordoma. That is the lesion here, and you have destructive lesion also involving the coccyx, no? Okay, but you do have blastic changes as well in this area, surrounding area. This is osteoblastoma, okay, and you can see the blastic change in the area of the pedicle of L5, no? Okay, yeah, this is okay, yeah, I have a picture of the clivus, so, so let's see if you can see it now. Yeah, that's the clivus in red. Okay, so it's part of the skull base, just anterior to the foramen magnum, no? And it is part actually of not the occiput, but the this looks like part of the sphenoid, no? Okay, correct me if I'm wrong. Okay, this is part of the frontal bone. Yeah, this is probably part of the sphenoid bone. Okay, the clivus. Okay, so if you look at the clivus, it's also very near the cord, no, especially the midbrain. Okay. So parosteal sarcoma usually seen distal femur, periosteal in the more distally into the involving the tibia. Okay, so this is parosteal sarcoma. Okay, at the distal femur metaphysis, no. Okay, where this one is periosteal. Okay, okay, there is bone destruction, cortical destruction on the lateral aspect of the tibial metaphysis, no. That's the lesion there. Okay, and you do have some soft tissue involvement as well. Okay, so again, some other locations, no? The pelvis, okay, like chondrosarcoma, okay, that's the lesion there. Plasmacytoma, and you can see that there are also lytic changes involving the body and the pubic rami, no, actually on both sides. Okay, so, okay. And this is chordoma. Okay. I think you've seen this already. Okay. some more subtle area of bone rib destruction. Okay, for example, look at this area here within the red circle. No? There is obvious rib destruction there. So what is this? Is this anterior rib or posterior rib? Hmm?
Posterior rib.
Yes, posterior rib. Very good. Okay. So again, chondrosarcoma. Here you have this looks like the area near the neural foramen. No? Okay. And eosinophilic granuloma. Okay, again, posterior rib involvement. Neurofibromatosis, and fibrous dysplasia also. So lesions involving the spine, okay, chordoma, aneurysmal bone cyst, metastatic disease, osteoblastoma. Okay. So this is an osteoblastoma, okay, right there. Okay, involving the lateral mass of this looks like C3, no? And yeah, can you see the expansile lesion here? Okay, look at this area here, no? That's a very expanded rib lesion, no? Okay, this is the normal this is how normal rib should look like, and this is the expansile tumor of fibrous dysplasia. Okay, so chordoma again. Okay, we've seen this before, no? So when you are entertaining metastatic lesion to the spine, one area that you again look for that is you look at the pedicles. No? So when there is infiltration, the pedicles, the pedicle disappears, and it's called the pedicle sign. No? And that's what you see here. The pedicle of this vertebra is no longer clearly demarcated, while here you have a pair of normal-looking pedicles. No? Okay, can you see the lost pedicle there on the right? No. Okay. So sclerotic cortical lesions, no? So sometimes with stress fracture, this is a repetitive type of trauma, minor trauma, and then the bone tries to um, repair itself, and then you'll have cortical thickening in the area of stress fracture. No? You usually see this like in the lower extremities, like the calcaneus, no? Where there is a constant risk for trauma because of walking or running. No? This is Brody's abscess. You have a nidus. You have a lytic lesion in the cortex, no, the mid shaft. No? This looks like this is probably the humerus. No? Okay. Okay. You have sclerotic changes in the medulla, and then you also have this is the fibula. This is the tibia. You also have a solid perosteal reaction in the adjacent fibula. No? So stress fracture, okay, maybe the bone is trying to heal itself and repair itself by producing uh, new bone at the area of stress. No? Okay. So lytic lesions in children, eosinophilic granuloma, neuroblastoma, and leukemia. Okay. So sometimes you see the lytic lesion in the skull. No? If you have multiple lesions like this of different sizes but rounded, one description is that's used is punch out lesions. No? Okay. So this is neuroblastoma and leukemia. Okay, you have multiple round lesions. No? Again, that's why another name is round cell tumor, no, for these types of lesions, malignant bone lesions. Okay, so lytic lesions in adults, no, mets from lung, kidney, and thyroid, and you may also have multiple myeloma or a primary bone tumor. Okay. So metastatic lesions tend to be multiple, no, in more than one area. Okay, so this metastatic lesion is from the thyroid, specifically thyroid carcinoma. No? Okay. You see lytic changes involving the body of the iliac bone on the right, as well as the proximal femur. No, okay. and even the pubic rami. Okay. So another lytic lesion, expansile. What bone is involved here? Can anyone tell me? Can anyone describe what specific bone is involved there on the right side? Anyone?
Pubis.
The
The pubis.
Yes. What particular area of the pubis? Starting with the letter
The,
R. The
the
rami, the
pubic
horn.
ramus.
Okay. So superior and inferior pubic rami are involved, no? Okay. So this is superior pubic ramus and inferior pubic ramus. And what do you call this opening here? What is this opening here? There's a one nerve that goes to that, no?
Obturator foramen.
Obturator foramen. Very good. Okay. So again, do not forget your anatomy, please. No, when you are again imaging, there's no escaping real anatomy with imaging. Blastic lesions in children, medulloblastoma, lymphoma. Okay, so blastic is you have increased opacity, and the increased opacity is usually blurred. No, the details not very clear. Okay, this is medulloblastoma and lymphoma. No, you can see from all the other vertebral bodies, this is most sclerotic. No? Okay, this is most likely what is this lumbar or thoracic vertebra? Hmm? Anyone? On a lateral view, your Q would be the absence of ribs. So therefore, this is most likely L1. No? There are no ribs found attached to this vertebral body. So blastic lesions in adults, if you're thinking of metastatic lesions, could be a breast, prostate, okay, and you include also on that list renal carcinoma, no? Lymphoma, Patch disease, and some other, etc. The some other less common lesions like mastocytosis and fibrosis and fluorosis. Sorry. So usually metastatic lesions tend to be multiple, no? Polyostotic in location. Okay, and this is actually prostate metastasis. No? In the For one reason or another, prostate metastases tend to be seen most commonly in the lumbar spine. No? Okay. One theory there is the presence of the Batson's plexus, no, connecting the systemic veins with the veins of these structures here. Okay. So breast metastasis, lymphoma, and this is an enchondroma. Okay, actually. So you may have benign lesions with non-sclerotic, meaning there is the edge of the lesion is not opaque. So hence the term nons without sclerosis. No, giant cell tumor, brown tumor, osteolytic phase of Paget's disease. That's also another example. Okay. So yeah, brown tumor. So it's another example. Okay. Paget's disease. You can see a very large lytic lesion involving the frontotemporal cranial bones. No. Okay. And when you do have soft tissue extension, that usually implies a malignancy. So when you see involvement of the soft tissues, it is considered malignant until proven otherwise. So, but you do have benign conditions with soft tissue extension. And a good example is osteomyelitis. No, you may start out this osteomyelitis may start out as cellulitis and then progressing to osteomyelitis when there is deterioration of the wound. No, especially when there's already pus formation. So this is osteosarcoma. Can you see the what type of periosteal reaction is this again? Anyone tell me?
Organs triangle.
What? What type?
Rodman's triangle. Doc.
Okay, can't hear you very well. Well, there is yeah, there is you can see the soft tissue involvement also, no? Aside from cortical destruction and I don't know if you can see there are very subtle speculations over here, no? Okay. So some lesions tend to be multiple, no? And again, the book mentions that if you have looking at multiple lesions, most often they are benign. No? But there are also malignancies with multiple distribution. So classic example is metastatic disease, no? Multiple myeloma, lymphoma, Ewing sarcoma, and osteosarcoma. Okay. So yeah, these are again examples of metastatic lesions from prostate carcinoma. Again, like I said earlier, the metastatic lesions with the primary coming from the prostate tend to metastasize to the lumbar spine. No? So this is multiple myeloma. Again, another name is round cell tumor. Okay. You see that what's involved is the okay, calvarial cortex, no? The skull of the calvarium, the cortex of the calvarium. So this is lymphoma. Okay, look at the blastic change. Okay, some more multiple lesions, osteosarcomatosis. No? So you have multiple areas of involvement. Okay, so in summary, okay, these are on the left side. I mean, on the right side of the picture, and on the left side, our comparison is being made with benign versus malignant lesions. No? So the clarity or the extension to the soft tissues, the orientation of the calcifications, and with the disrupted cortex, you tend to favor the malignant lesions. No? Okay. So again, this table summarizing the age group versus the pattern of okay, pattern of destruction and the specific conditions. No? So, so we see 40 plus, you have metastatic lesions found in all three patterns. No? So again, this is just a repeat of the first slide I showed you. Uh, the When you do pattern identification, if there is a loss of bone density, that's a lytic lesion. If there is increased opacity, that's sclerotic lesion. And that can be applied to the edge of these lesions, the cortex. You may or may not have sclerotic margins. And age is also important. Here you see it's less than 30, but some books will say less than 40 and more than 40. Location is also worthwhile to consider because there are lesions that tend to occur at the proximal or middle third or in the other areas of the bone. No? So, and the other miscellaneous information as well. Okay, so I think this is my last slide. Okay, I show you these examples. Okay, so letter A, what pattern of bone destruction is letter A? Is it benign, malignant? First, tell me if it's benign or malignant. Letter
Malignant
B.
dogs.
Okay, what type specifically of cortical destruction is this?
Codman's triangle is there.
Yes, very good. How about this one? Letter B.
Sunburst. So
Sunburst.
it's
Very good.
also
Okay. So
malignant
how
dog.
about letter C? C, does it look benign or malignant to you?
Osteolytic.
Well, not
Benign dog maybe.
it's benign. Yes, this is continue. The cortex is continuous. No, there's no disruption of the cortex. So this could be the osteomyelitis too. No, for all we know. And this one is this is
Malignant dog.
called as
Onion skinning is there.
onion skinning. Very good. Okay. Okay. So again, there are lesions that display loss of bone density or lytic lesions. No? So there are what you call benign lytic lesions which you don't have to do biopsies. These are the so-called do not touch lesions. No? So they come by different names. Leave me alone lesions, don't touch lesions. Okay, there is a repeat. Sorry for that. But you basically leave the skeletal lesions alone. No? You can observe. No? And usually, perhaps one clinical clue of a possible worsening of the condition is when there is already pain. Pain can indicate many things. Of course, one common reason for that is there could be a pathologic fracture, no? Or among other things. But when the vision is painless, then you tend to be a little more cautious, no? But when there is already pain, then you have to investigate further, no? So these are skeletal do not touch lesions are so characteristic that you don't need to do further diagnostic tests, no? I don't know if you've come across this term, no? The Aunt Mini diagnosis. Aunt Mini, well, it's an expression by the one of the American radiologist authors, no? So it's the logic there is if you see Aunt Minnie in a room, that is Aunt Minnie and no one else. So it's like I've been seeing a tumor for the first time and knowing what the tumor features are, then that's what is called as Aunt Minnie diagnosis. No? So again, these do not touch lesions do not require biopsy, and they can be misleading, no? And may even lead to more radical treatments like amputations, no? And there have been many instances where um, on the basis of biopsy findings amputations were done only to find out on a review of the biopsies that they turned out to be benign. So and again, there's always the fine edge, no, and the decision making, because you do have to act very quickly, because like for example with osteosarcoma, there's a good chance of spread of the malignancy further, no, in different areas. So again, you have to balance between deciding very quickly and also leaving some of these do not touch lesions alone. Okay, so the categories, the three groups of these do not touch lesions. Now, these are some of lesions are a result of trauma. Post-traumatic lesions, usually bone tries to repair, and you can mistake the growing cell as a malignancy. Some of these are also normal variants, no? Like for example, osodontoideum is a incomplete fusion of the odontoid process to the body of C2. So you can mistake that as a lytic lesion, but that actually is a normal variant, no? So lesions that are real but obviously benign, no? So these are some examples. Bone island is when there's focal sclerosis, and you see this most often with long bones, no? Like for example the ribs. In my experience, I've seen most of these in the ribs, no? So you have to differentiate that from other lesions. But these are all benign lesions, no? Tag lesions, osteotuberculosis, pseudotumors, bone infarction, no? When the bone becomes devitalized, no? You usually see a lot of these happening with bones that have very limited collaterals, no? For example, the scaphoid bone at the wrist, the femoral neck, no? Okay. The damage happens on these blood vessels supplying these areas, then there is a big chance of occurrence of vascular necrosis. No? I think this is my last slide. No, so again, all the other topics I've not touched on, I will try to discuss in the next session. No? For example, trauma, maybe metabolic bone diseases, and maybe arthritis as well. No, like I said, this part is from chapter 55 to chapter 61 of the brand. No, so it's a really broad topic. No, so but again, I would encourage you to read. No, if again if you have time, but uh, the things that you have to know are the more common lesions. No, the rarer ones are what you call good to know information, but again, what is important are the more common lesions that you should be familiar with. No? Okay, are there any questions? Okay, so I had to go very fast because I had a lot of slides to show
Yeah,
you.
doc.
Yeah, I'll be posting the PDF copy of this, no, as well on iLearn or maybe on TG, depending on which one is easier to do. Okay?
Doc, I have a doubt.
Yeah. What is it? Who's talking?
Doc,
Pandi? Mm.
yes, Doc. You told before you showed the picture about the giant cell tumor and aneurysmal bone cyst,
Okay.
and they
Giant
were
cell.
appearance.
Mm-hmm.
Their appearance is almost same for both of the tumor, and the
Yes,
location,
yes,
just location is different, epiphyseal and metaphysis, but
yes.
appearance is same. How to differentiate them, doc, if they're
Okay,
given alone, like?
okay. So one feature of osteoblastoma, okay, is the presence of sclerosis. I don't know if I mentioned this, no? The presence of sclerosis, no? Usually, aneurysmal bone cysts do not show any sclerosis, but the ballooning or the expansile change is very obvious, which may not be very obvious in osteoblastoma. But in osteoblastoma, you have the more common pattern that differentiate, although again, both can be expansile, no? But the more prominent feature of osteoblastoma is the presence of sclerosis. That's why you see the term blastoma. Now, whenever you see the term blastoma, expect to see some sclerosis, even prominent sclerosis, no, meaning increased opacity of the lesion, no. Okay, similar to this, no, like this, no, there is increased sclerosis. Uh, when you're dealing with giant cell tumor, you tend to have just mostly lytic lesions with minimal or very less amount of blastic change or sclerosis. No? Did I answer your question?
Okay, doc, almost.
Anyway, yeah, you have to. I'll talk about that in detail, and I'll attach it to the TG. No, so you're confused differentiating between giant cell tumor and which one was it?
Aneurysmal bony cyst, doc.
Unusual bones is I thought we were sorry. I was okay. Um, okay, so let's see. Giant cell tumor and unusual bone cysts. Okay, ABC. Okay, so probably one differentiation there is in the age group, no. Uh, Although again, both are very near, occur very near the joints, no, the epiphysis. If you look at the giant cell tumor, usually is the 20 to 40, no. Aneurysmal bone cysts occur much younger, 10 to 20. But like I said, no, the sometimes the differences can be very subtle. But in my experience, no, in my clinical experience, when again you look at the term giant cell, the you don't say anything is giant unless it's really very big. The expansion is very obvious, no? Okay, so maybe even the size is also one differentiating point. But I guess I think one differentiation is the age group where it occurs, no? Anyway, I look into that further, no. Again, that's why, and both are benign, mind you, no. Unusual bone cyst and giant cell tumor are benign lesions. Sometimes they come up when there is the occurrence of pathologic fracture. Again, when the bone expands, the bone becomes inherently weakened, no. So a lot of times, the pathologic fracture is what leads you to discover the presence of these aneurysmal lesions. So I'll look into that in more detail. No? I'll attach it to the TG group. Okay, it's okay with you, Pandi?
Okay, doc. Okay, doc. Thank you,
So
doc.
yeah, so so again, very most important feature, clinical feature is the age, no, and then of course, uh, the other radiologic features are in the appearance, no, non-clinical or more of radiologic information that you may get, no. Okay, so that is why also it takes also experience to be able to narrow your differentials, no. So if you've seen a lot of these cases, like probably I have, no, although some of these other tumors are very rare, no, but in terms of incidence, in terms of malignancies, osteosarcoma is also common, no, and tend to occur in the younger age group. Okay. Okay, so I just post the answer to your question in the TG group, so you have a better. But try to read up on that also, Pandi. Okay.
Okay, doc.
Okay. So, and are there any other questions? So, if none, anyway, if you can think of, maybe you can think of other questions, just please post them on the TG group, no? And or even message me on the privately. I'll try to answer as best as I can. Okay. So if there are no questions, then I'll stop here. So thank you for listening. We will have another session discussing the other part two, no, musculoskeletal radiology. Okay, so I'll end here. So take care, everyone. Okay, please read, no. Okay, do not rely just on the PowerPoint. Okay, bye for now.
Thank you, Doc.
Thank you,
Thank you.
Doc.
Take care.
Thank you,
Take
Doc.
care,
Thank you,
everyone.
Doc. Thank you, Doc.
Okay,
Thank you, Doc.
bye.